and bang, and if it doesn't go, okay, you keep hitting your head against it. Women look much more for a consensual kind of arrangement. So perhaps when you feel a joint barrier, that to us is a challenge, okay? Whang, bang, and move it, and it moves. Perhaps with women it's more feel it, okay. How can we do what's best for that, for me to do it and for that joint to move? And what I often find is that when we're doing things and you say, look, here's the barrier, and what I want you to do is you've got to hit that barrier. What I find people doing is this. And coming back, because I don't want to sort of have that obstruction which you go through and then you see what's happened on the other side. And I think there might be something of that in this business. If you look at chiropractors, 99% of men chiropractors use manipulation. 30% of women that are chiropractors do not use manipulation. So, I think what we've got to try and do is to sort of think about that, and also to say to yourself, can I develop now, and I've got a couple of my female staff kind of doing this, can I develop now a little series of quick exercises which go against something that I can practice so that when I come to doing the manipulation course, I can do this. With men, the great risk is that they do far too much and they are damaging. We don't seem to have any great doubt about moving something. The whole problem is saying, oh God, don't move it like that. You've got to kill that patient. That's the problem with men. But with women, it's getting that thing. And so once women develop the skill for manipulation, they're just excellent. You can ask Anne if that's all up the wall. But there is basically but why the problem is, I don't know. But there certainly is more difficulty teaching in a female to manipulate than men. Men, it's definitely a matter of cutting back. But it's perfectly possible to do it. But I think you might have to do a little bit of a preparation stuff of just practicing quick things. You know, that might be worth doing at this stage. I was going to mention that at the end, but it just came up now. It's nothing to do with this course. But the next course, and manipulation, is an important aspect of what we do. It's very useful. And we're building up, with all these coupled and combined movements, a system where we can move and move and move. Or we can just do that. And under certain circumstances, that might be even better than moving and moving and moving. I would say, though, that if somebody said to me, okay, you can choose to manipulate or you can choose to mobilize, but you can never do both, I would always take mobilizing. It's a much, much more powerful tool. There is no question. And I want you to remember that manipulation isn't, or mobilization isn't the technique done by people that can't manipulate. You know, once you've learnt the 7th Dan black belt technique, all you do now is kind of quick things and paralyze. You kind of do all the other stuff. You can do everything. But mobilization is so powerful from all kinds of points of view. It's much more universal in its application, for one thing. Secondly, it can be done in a rhythmic fashion as it is, of course, and it has a much greater effect on input and on vascular changes and on changes in muscle. So mobilization is huge in its application. And when you're doing something that is repetitive, you're creating good engrams about what this movement is. And the patient can take over from that and do the movement themselves. But you come up and click like that. What does that teach them? Sometimes it restores motion, it cuts down on the input into the central nervous system, and it's a powerful tool. But it's certainly not as universally applicable. So, here's something for you to work on, because I'd like to know what the answer is here. I've kind of theorized on this problem, and I'd like you to sort of come up with some answer here. Anne would probably be better at this than me, because she's had much, but we all teach everybody to manipulate. And it's just getting over that barrier, whatever it is. Is it physical or is it a mental thing? I don't know.
Well, I can really relate to that because I had 11 years of ballet, and I'm taking Taekwondo right now. And sparring is the most uncomfortable and unpleasant thing for me because you have to make noise and you have to punch and kick at another person, and right now I still really hate it.
So, I am woman and I am invincible. All right, next one. Very interesting, all this stuff. You know, why do we have barriers about to do things? I don't know some of the time. Just don't know. Something going around in our heads. Very interesting. Okay, just have a couple of minutes break. And then we will start on some practice. Now, when we look at the thoracic spine as far as treating is concerned, I think we could divide the examination into 3 or 4 phases. The first phase is to do a screening examination. That is to do 3 things. It's to eliminate those cases that we shouldn't be looking at. For example, if somebody's got clonus and an ataxic gait, we want those out of it. We don't want to be continuing with our examination. But we need enough to be able to communicate with the referring doctor, or if we're doing it as a primary care, to find a referring doctor, or to find that we refer to a doctor to whom we refer, and get rid of this patient. Secondly, we need to try and sort out those cases where the pain is coming from elsewhere. Because if it's coming from elsewhere, we need to be looking elsewhere and not spending lots of time on the thoracic spine as our kind of primary investigative area. And thirdly, I think we need to recognize signs which, although they don't constitute a contraindication to treatment, certainly flag you that there are certain procedures that might be beneficial and certain procedures that it would be unwise to do. And so when we look at the screening or the scanning examination, what we need to look at is the presence of a dural sign. How do you pronounce dura? Dura. A dural sign. Okay? Secondly, we need to look at signs which indicate cord compromise. Perhaps we need to look at the level or the area of involvement to give us an idea of where to focus. And this is something we can perhaps do very early on. We need to exclude the cases that it isn't the thoracic spine. Not exclude the patients, but exclude a lot of attention being placed upon the thoracic spine if it's coming from elsewhere. And then we can go into our standard examination. Leave fall for a moment. This is something we should think about. It's one of these signs that Stoddard talks about. We're not going to test it at this stage, although perhaps you could. And I'll just speak about that a little later on. I must say, in practice, I tend not to, because it has let me down on 1 or 2 occasions. So if it lets you down, how certain can you be about how significant it is? I think it might be very significant if it's there, but it doesn't necessarily mean you're free and home dry if it's not there. Certainly, if it's positive, it's very much a sign we should look at. Then we could go through what we would look at with any of the spine. We do our architectural examination, which could be the postural examination. We could test active movement to find out which of the movements we're going to test as our salient signs at some later time. And then we will get into doing the segmental examination to decide what we're going to do. Which is the area, what is the joint movement that is lost, how are we going to restore it? And we can do that in sitting and in prone lying and in side lying. Or, if you've come through the muscle energy approach, you would be doing an analysis of local segmental active movement, wouldn't you? Looking for flexed and extended lesions, or looking at the positional faults of ribs and so on. That would be their approach. I find that the passive movement approach in the thoracic spine is more effective than the muscle energy approach. On the ribs, I think that the muscle energy has got a certain amount to recommend it, I must say. But in terms of thoracic spine, restoration of function, I feel happier with the mobilization and things that we do because the techniques are really sort of excellent. So, let's just have a look at what the screening examination should constitute. Then we can practice it. Then we can just run through quickly the examination. Now, how much on the thoracic spine have you done? Yeah, it's a problem, isn't it? You do the neck and the back and time runs out and the kind of thoracic spine gets kind of done quickly and the ribs perhaps not at all, and you hope you'll pick it up next time and another instructor comes, and it's sort of like an area that's missed very often, and it shouldn't be missed. If it constitutes 40% of your practice, and if it constitutes, you know, like 40% of anybody's practice, perhaps it should constitute 40% of all of our practices, because it's such a good area. So, let's see how we go. Let's go to the beds here. Right, Sir Cougar. Onto here. Yes, please. Right. Let us have a look to start with at the main features here. All right? And to me, the main features would be the presence of a dural sign and the presence of chord signs. Then we can sort of go back and try and exclude those that are coming from the neck and so on, and then focus in on the thoracic spine itself. That would seem to me to be the best way. So, for the dural sign, what are we doing? We're taking the head forward like this, and we're coming down and we're asking the patient about discomfort or pain that is producing. So we take the head into forward flexion. Now, that is a combination of things, isn't it? It's moving the spinal cord and its meninges, but it's also moving the joints of the thoracic spine into forward flexion. So, what we need to do is to produce the discomfort. So we come down in that position there and then take it back. Then we take one or both legs and we extend them so that by going through the sciatic nerve we pull the meninges, the dura, downwards. And we see, is that causing any pain up there? Now if that did, that would be a bit significant because certainly doing this isn't moving these spinal thoracic joints in any way the same as that is doing. Now, next thing that we can do, having established what that basic thing is here, is to take the head forward like this to the point of pain and then just ease off a little bit so it's not hurting. Now what I'm going to do is to take both legs like this and extend them and see if now that causes any alteration in the pain. If it brings it back, it's got to be because of movement of the dura, because certainly we've checked out that this isn't causing any pain when we did it by itself. And so as we take it forward, back off, or what we can do is to leave it up here a little, stretch the legs out, have a look now and see as he goes down that he can't even get as far as he could before, or it's hurting more. So they're all manifestations of looking at the dural motion. And remember, the dura is tightened in flexion. It's concertinaed in extension. And as we go into flexion, that concertina-like corrugations are straightened out. So that would be how we would look at for a dural sign. Now that doesn't constitute a contraindication. But if we see a dural sign, it means that it's irritable. It also means that we're kind of questioning a little bit the disc. But then frank disc lesions in the upper part of the spine here are practically unknown that come to surgery anyway. But we could have space-occupying tumors. We should have that on our previous list, for example. We mentioned tumors, but really bone tumors. But we can get all of these tumors affecting the cord and so on that are space-filling tumors, as opposed to tumors that might affect the stability and so on of the bone. So this is two aspects that we could have had on our earlier list. See how that sort of thing works? It just sort of, ideas come just out of your mind, just randomly like that, and that's why it works so well. Next thing that we would do is to examine now the presence of upper chord signs. And we can do that by having a look at the hyperreflexivity of the knee jerk, of the ankle jerk, like this. We can look at, of course, the patient's gait as they walk in, but very often we don't see them walk in, do we? They are laid down or something before we see them. And that's probably not the best thing, so we should perhaps ask them to stand up and walk. The next thing, and certainly I would if I found any of this sort of active reflexia, then we would look at the patient. I'll just take his shoe off here. Okay, and I'll come up and I'll come into the sort of Babinski sign here. Okay, got a little worried there. All right, coming around here. We would go into doing the clonus, which is just to take the foot back and just a little overpressure. And many people have a couple of flicks. It's if they've got more than two. Bang, bang, bang. The Clonus Society has declared more than two. All right? And we can do this through the foot, which is the usual one that we do. You can do it through the knee with the patient laying in long sitting. But the problem with this is that then we start enacting dural problems again. So I think that in this position, it's probably adequate that we can test all of these things. The hyperreflexia, the presence or absence of clonus, the presence or absence of the Babinski sign. Now, for those people that are very hyperreflexia, or reflexive, we can look at them and just have a quick check of the upper limbs. If the upper limbs are, we can then ask them, have you always had these excellent reflexes? People take a great deal of pride in having these excellent reflexes, okay? Yes, I've always been like that. Everybody says I've got really good reflexes. Okay, perhaps this is not significant, but if this was kind of just normal, when we looked at this, and we come down here and it's doing this, this would be a very significant sign that there is a difference between here and where the centers of activity of these spines are. So that's a very important test and should constitute a very early part of your screening examination. But this is a little bit more thorough than the dural, so we'll do the dural first, and then we can go into this as the next area. Now, having established that, perhaps there are a number of things that you can work out for yourselves. Some of this could be done as far as the cervicothoracic junction, for example. That's part of the thoracic spine, it's just a regional zone, which we did yesterday. But if we take the head forward, for example, like this, and it produces pain, is it possible that we could sort of get the patient now, having established that there is no dural irritability, to say, now, I want you to take your head right forward, but not to take it any further forward than when you feel this is stretching here, so that we can not allow that flexion to occur in this part of the spine. If that causes the pain and we're not allowing any movement to occur here, probably it's the flexion of the cervical spine that's causing the problem. On the other hand, many people get the pain in this area as they come into extension. Is it being stimulated into this area because of compression of the low part of the cervical spine, or is it as these movements of the thoracic spine go into extension? So what do? We just say to the patient, just slump forward here like this. And now I want you to extend your head. Now they're extending fully but holding these flexed. And if it doesn't hurt, the next thing to do is to say, now, one joint at a time, I want you to try and extend. Oh, there it comes on. Okay, so there it's giving us an idea that perhaps that's the area that we should be kind of focusing with. And so there are a number of these little things which you can work out your own group of looking at coupled and combined movements. If we have rotation, for example, that should hurt, if it's the cervical spine, with side bend, because there are sort of a different movement. On the other hand, in this upper thoracic spine, we've got these two movements the same, side bend and rotation in the same direction, but of course the side bend is nothing like as efficient because the ribs stop this. And so we can do a whole variety of kind of things. Look at the side bend. That still causes the pain. Well, side bend isn't so efficient here. So I would be thinking of the cervical spine. Whereas rotation is a movement that's relatively good in the upper thoracic spine, as it is in the neck as well. So we can sort of sort all these things out. And I've been experimenting a little bit of late with doing movements, let's say a rotation this way, but sort of holding these in an opposite rotation before you start. You know, so we kind of prevent that rotation from running down into this area. So just look at how can I do a movement here but not do the same movement down here, and then how can I couple these things together? This is very useful. All right, now, we've got the pain pattern, and if he's talking about pain in this area, I would be looking in this area. I wouldn't be seeing if the cuboid was displaced or some other thing. That's not how I practice. But I'm sure I miss some of these things that are very remote. But these might be only constituting like 10% of the weird ones that don't clear up. But for the vast majority, if you find a problem in this area, it seems to me reasonable that we should spend a bit of time looking in this area instead of sort of getting off track in some remote area of the body. That would be how I would look at this. But perhaps on a Quadrant 3 Level B, Course B, perhaps we should be looking more remotely. But this is certainly not the way I practice, and so that's not the way I'm going to show you what I do, because I don't think that's ethical. So what I'm going to do now is to do two little focusing procedures. And these two focusing procedures, you can do either one, but not both, I don't think. Can you come up and sit at this end? Just this way, please, just so you're a bit closer to me. Okay, there are two procedures here. One is a postero-anterior glide motion, which we can do simply by taking the patient's arms like this, or just putting his arms across his shoulders like this. And all I'm going to do is to just hold the arms and just do a little backward-forward glide like this. Now, what we're looking for is a slight degree of stiffness. After all, this translation might be like a millimeter. We're talking about a very, very small translation, or less. Okay? But we're looking for how does it feel? Is there more movement, or is there certainly kind of rigid movement? And this kind of feels a bit stiffer here to me. So the backward little movements are the same as we do in the lumbar spine, just pushing through the femur. This is what Olaf Evianth does. I prefer the one where we just put the arms at the side like this and just take hold of one shoulder, and I'll just kind of move you back a bit there. Okay. And just place our hands on the spinous processes and just take hold of the shoulder girdle and just gently rock it. Now, we're not trying to determine how much in terms of degrees is lost. We're simply trying to say, how comfortable does this little oscillating movement feel? Or does it feel a little stiffer? We are seeking a consensus. So all the women should be great at this, okay? How is this reacting to me? Have you read Deborah Tannen's book? Wonderful little book called You Just Do Not Seem to Understand. Conversations between men and women. It's like two species not communicating. Unbelievable. She's a linguist at Washington University, and Georgetown University in Washington. Just a wonderful, wonderful book. It's in paperback now, well worth getting. Okay. So, I'm just going to come down here, and all I'm going to do is just to sort of feel for where there is sort of like a stiffness. And that'd be the area that I'd be kind of concentrating on a little bit later on. So I would just sort of move down here, just sort of feeling, how does it feel? Does it rock, and does it feel happy when I do this? I mean, that's what we're looking for, isn't it? Joints that this doesn't threaten, or it's a bit kind of tense and tight. It's facilitated. Okay, and then we can go the other way and sort of just do a little oscillating left rotation. And all I'm doing is just trying to sort of think to myself, I should be looking around at that particular area there as I go down. Some of you might find it easier to do in sitting. Some of you might find this easier to do in lying. If you choose to do this early test in lying, the problem is we've then got to sit the patient up again and start doing all the active movements. So let's just take that this forms part of the screening examination, either this one, which I'd like you to just try, or this one. So now we think, okay, we've got a kind of a segmental problem here. We need to sort it out a little bit more completely, but at least we know that it's here. We may have problems elsewhere, but this needs to be treated. And there's no contraindications to our continued examination and our continued treatment. Or if there's a dural sign, we need to be a little bit more careful in planning, but all of these are not going to threaten it. I mean, this is nothing like sitting in your car, is it? These movements, these are very, very gentle movements. And so that would constitute, to me, the basic first part of the examination. Now, we will go on, and then you can just run through all this yourself. Then the next thing would be to simply do what we do all the time, which is to say, bend forwards and look at movements, if you like, bend backwards. Let's have a look at the postural thing. Let's have a look at the movement. Just part of our architectural examination and part of our movement examination. And then just side bend down like this, not worrying too much about all the combinations, just seeing how he does it. And I've demonstrated a bad technique there. I should be happy enough just to let him do it. If you say to a patient, now I want you to move, well, we should let them move and not superimpose them how we want them to move. So, bend forward. And we watch that, and I would watch it from here, of course, and then perhaps from here. I'll stand here so that I don't get in the way of the video. And now extend, and I would look at that extension there. Okay, now can you go into side bend? And we'd look at the general curves and where they take place, and side bend the other way. And now can you rotate? And can you rotate back the other way? One very good point is, you know, if patients are complaining about breathing patterns, is it breathing because as we extend it bothers it? Or is it as we breathe out it's flexed? Perhaps we could sort of do the same thing for the ribs as we did for the cervical spine under these circumstances, like this special little thing. We could say, right, I want you to hold yourself forward like this and now breathe in. Although it's not such a big excursion, very often, if it's a rib problem, that will cause the problem. And we know because we're holding it in the flexed position that it's not the ability of the spine to go into extension. On the other hand, if we're sort of trying to work this out, we could say, now don't breathe at the moment, just extend your spine and see if that hurts. It doesn't automatically mean there's nothing wrong with the rib, but it means that if we now have no pain there, and then we say, now, I want you to just hold yourself downwards in a slightly flexed position, now breathe in, and there's pain, that the ribs are probably implicated rather than that extension accompaniment that goes on with the ribs. So we can fit in a few of these coupled activities just to focus us on where to really look.
Does it also fit in that they don't have their discomfort going into the extension, but they have it coming out of it?
Mm-hmm.